But what I'd like to do is move on to the emerging area of using these biological combinations, particularly CDK inhibitors in the adjuvant setting for clinical benefit, and also in the neoadjuvant setting to maybe understand something about the biology and to provide us some baseline data and justification for these trials. Ian, there were several studies looking at both neoadjuvant the neoadjuvant model in defined subsets. You want to comment on those findings?
Yeah, so we've already known that in the pre-CDK era that in the neoadjuvant setting for ER-positive breast cancer that neoadjuvant hormonal therapy was at least equivalent to neoadjuvant chemotherapy in aggregate in unselected ER-positive breast cancers in terms of clinically important things like leading increasing rates of breast conservation. And those are old data. And now that we have the advent of CDK4/6 inhibitors, which clearly improve the efficacy of hormonal therapy, it's certainly worth revisiting this and say, are now this combination even superior to chemotherapy? So there was this interesting study in the neoadjuvant setting, the Coraline study from the Solti group, which actually kind of picks up on, follows up on the Pearl study that you were talking about in the metastatic trial. So this trial looked specifically at luminal B ER-positive cancer. So we're kind of stacking the deck essentially against hormonal therapy, randomizing patients to a ribociclib and hormonal therapy, an AI for 6 months versus a neoadjuvant chemotherapy regimen, basically Q3-week AC with weekly paclitaxel. And again, these are luminal B cancers, but when they looked at their primary endpoint, which was ROR low-risk score, essentially equivalent effects, which I think is certainly supportive of this idea that for patients with ER-positive breast cancer, that neoadjuvant hormonal therapy can be a very effective approach. Now, I think the one caveat that was brought up at the meeting was that this particular primary endpoint of ROR score was generated and validated in pretreatment patients. So in this particular setting where they're using it as a post-treatment endpoint, my understanding is there's not a lot of validation for that.
Or any.
For any. trying to give them the benefit of the doubt.
You're being nice.
So I think that that's something that we need to follow up with. And there needs to be, potentially longer-term outcome data and also, other endpoints. But it's certainly encouraging. We already know from other preoperative studies that hormonal therapy plus CDK4/6 inhibitors are, essentially 100% effective at leading to a drop in Ki-67. So, I mean, they're effective. I think what we need to do now is really try to focus on which patients benefit most with ER-positive disease from chemotherapy and which can get by very well with neoadjuvant hormonal therapy. My guess is the vast majority hormonal therapy is going to be fine, but there probably are patients who still benefit from chemo, and it would be nice to figure that out.
And I think certainly the large national, international randomized trials going on now, many of them are biomarker rich, to not only answer the global question of the benefit in the adjuvant setting, but hopefully some about the biology and maybe patient selection, we hope.
And if we get data from the adjuvant trials, I mean, we have 4 trials that we'll someday report. One's still ongoing, Natalie, with 3 years of ribociclib. We have the 2-year studies of Monarch and Pallas, and then we have the 1-year post-neoadjuvant study of Penelope, which we thought would report, earlier than the others. I mean, all of these trials, probably Natalie the least, really focused on high-risk disease and tried to amplify that. Monarch probably is the highest risk population, and then Penelope B. So, trying to make it not be a 10-year difference in recurrence, but more 5 or 3 or 4. But, if those are positive, it's going to be interesting to see what it does in terms of changing our neoadjuvant approach as well.
But none of those, I was going to mention this, none of those trials, they're all high-risk populations, and high-risk people will get the chemotherapy. That's the issue. None of them address the problem, the question of, in a high-risk patient, do you take like the Coraline way of just endocrine therapy and the CDK4 and nothing else?
The West German study group is going to do that.
They're going to do that, but it's a smaller, trial.
But it will be done. We're going to get some
So
data.
assume for a minute it's like a couple years from now and Pallas turns out to be positive, okay, for the CDK4/6. Somewhere Penelope B, where I agree with you, where's the data? I think the trial closed a year or 2 ago. And so assume they're positive. would that make us not use chemotherapy in the neoadjuvant setting?
No, I just think that you might select a group of patients out and feel even more confident about a West German study groups type trial, because maybe we feel a little anxious now, and then when they get their neoadjuvant therapy and they have a lot of disease at surgery, we still give them chemo, you know.
Right.
So I think, and they're all got Ki-67 less than 5%, but we don't want to not give them chemo. And also, of course, the ongoing RX responder trial will give us some information about that too.